So our next topic, Simplifying Antibiotics, is presented by Dr. Andrew Darkow. He's a pharmacist, and his title is Clinical Associate Professor, Internal Medicine Clinical Pharmacist at Campbell University, and he's also at Duke Regional Hospital now. I believe my friend Paula Walker turned me on to Dr. Darkow, and so we all owe Paula a thank you. It's wonderful, wonderful to have local talent presenting for us. And so, Dr. Darkow, please feel free to share more about you. You know, since we've met through email, really, and just met today. And he's one of these guys who, he looks like his picture so many of us use that picture from 10 or 15 years ago, and right when he walked in, I knew who he was. And so if you could welcome me, or join me in welcoming Dr. Darkow to the podium. So you can just advance here, and if they have questions, just repeat questions.
Okay, sounds great. All right, thank you so much for that introduction. Again, I'm Andrew Darkow. I'm originally from Washington, North Carolina, on the east part of the state. I went to Campbell University, so that's why I got the orange tie. Go Camels! And I work at Duke Regional Hospital with some of the best technicians in the world. So thank you all for having me. And I'm really excited to talk to you today. We're going to be talking about, I'm going to give you a 50,000-foot view of a microscopic topic. Hope to simplify antibiotics a little bit. This is one of the most confusing topics for my students when they come with me on rotations. Why are there so many antibiotics, and which ones do we use for each type of infection? So hopefully we can talk a little bit about all the different types of bacteria, and then all the different types of antibiotics, and apply some of those principles as we look into the treatment of pneumonia specifically. So our objectives, first we're going to recall the role of antibiotics in the treatment of infections, including pneumonia, and then we're going to describe the differences in bacterial coverage between antibiotics so that we can make sure we're using them appropriately and safely. And then finally, we'll discuss common types of pneumonia, including the corresponding antibiotic therapies for each type, because there's several different types of pneumonia with a few different nuances in treatment. So this is sort of the presentation roadmap, so you know what to expect as we move through this presentation. We're going to start by introducing bacteria, the different types of bacteria. We're going to define bacteria and define infections, and then we'll move into our antibiotic overview. We'll talk about what are antibiotics. We'll differentiate the different types of antibiotics, and then talk about some antibiotic prescribing principles, and then a little bit about side effects and allergies to antibiotics. And then finally, we'll apply that information to pneumonia treatment, talk about defining the pneumonia and how we can diagnose pneumonia, talk about the common pathogens that we would expect to see that would cause a pneumonia, talk about how we select our treatments for pneumonia, and then talk about how we monitor some of those specific antibiotics that we'll see. So first we're going to start off with that introduction to bacteria. So bacteria, what are bacteria? Well, these are microscopic, single-celled organisms that thrive in many diverse environments, and there are bacteria all around us and on us, from the tables that we're sitting at to on our skin, inside of our bodies in many different locations, on our food, etc. And they outnumber our own body cells 10 to 1, so there are more bacteria in our body than our own cells. So they thrive and live in symbiotic relationships with our bodies. The highest number of bacterial species in our bodies are actually in our gut. They help to promote proper digestion and prevent infections and help with immunity as well. And they can be commensal or pathogenic. So a commensal bacteria is the happy bacteria that lives in our bodies and helps with our essential functions. But there can also be pathogenic bacteria that are what cause infections. And typically our bodies are able to keep bacteria at bay, but sometimes maybe we'll have a breakdown of tissues, or we may become a bit immunosuppressed, and then that may make it easier for those pathogenic bacteria to take hold and cause an infection. There are many types of bacterial species, and these are just a few genuses of bacteria, and within each genus there are many different species. So we can see Streptococcus here. There are many different species of Streptococcus. There's Viridans group Streptococcus, Strep pyogenes, many other species. So these are all just genuses of bacteria, and each genus has many different species within it. And I've listed these, some of them in purple and some of them in pink, and we'll talk about why that is later. But some of these are gram-positive bacteria, and some of them are gram-negative bacteria, and we'll talk about what that means shortly. So how do we identify bacteria? We need to identify which bacteria is causing an infection. What kind of tests can we use to identify which bacteria may be causing an infection? Well, there's numerous different tests, a few of them listed here. One being a gram stain, which is one of the most common tests used to differentiate bacteria, and that's what we use to differentiate those pink and purple bacteria, the gram-positive and the gram-negative. And we'll talk more about that on the next two slides. We can use enzyme tests to test for the presence of different enzymes that bacteria use for their essential functions, like catalase, which breaks down hydrogen peroxide, coagulase, which breaks down blood. We can test for the ability of bacteria to ferment sugars and use those sugars for energy. We can test for their ability to hemolyze blood, hemolysis. We can detect different protein or DNA sequences in bacteria, sort of like genetic testing. And we can detect antibodies against bacteria. Our bodies fight bacteria by producing antibodies. So we can test for the presence of antibodies against certain bacteria, such as H. pylori is a type of bacteria that we can test for the antibodies against. And there's many other tests, but these are just some of the most common ones. So we talked about gram-positive and gram-negative, and I want to sort of talk about the difference between that, because that's one way that we can differentiate. Say if in theory about half of bacteria are gram-positive and half are gram-negative, if we identify that the bacteria is gram-positive, then we know that it's not one of these gram-negative bacteria, and that can help us tailor our antibiotics appropriately. So a gram-negative bacteria, you can see, is going to have an outer membrane and then a very thin peptidoglycan cell wall. So peptidoglycan is a carbohydrate, which is what bacteria use for their cell walls to help protect them and house all of their essential organ functions. So gram-negative bacteria are going to have that very thin peptidoglycan cell wall, whereas gram-positive bacteria are going to have a very thick peptidoglycan cell wall. And we can use a test called a gram stain to identify bacteria as being gram-positive or gram-negative. And we'll talk about that on the next slide. So the gram stain is a staining procedure that we can do to bacteria before we look at it under a microscope. And at the end of this procedure, our bacteria are either going to stain as gram-positive or purple or gram-negative or pink. And so the way that occurs, it's a four-step procedure. The first step is we're going to put bacteria onto a little glass slide, and then we're going to apply a stain called crystal violet, which is a deep purple color. And then we're going to follow that with iodine, which is going to be a mordant that's going to bind to that crystal violet and hold it inside of our cell wall of the bacteria. We're then going to follow that with an alcohol wash. Now, our gram-positive bacteria, because it has that really thick peptidoglycan cell wall, is going to retain that crystal violet purple color inside of it, whereas our gram-negative bacteria have a really thin cell wall, so they're not able to retain that purple color inside of it. It'll wash out. So they're going to look colorless at this point, which is why at the next and final stage, when we apply a pink stain called safranin, those gram-negative bacteria are going to become pink, whereas the gram-positive bacteria, because they have that deep purple violet still retained inside of them, they're still going to look purple because purple is more prevalent and deep than the pink color. And so at the end of all this, we're going to have a slide that'll have either pink gram-negative bacteria or purple gram-positive bacteria. And then that's going to help us decide which way we should sort of tailor our antibiotic therapy. So what's an infection? Now that we've talked a little bit about bacteria, where they live, where they thrive, and some tests we can use to identify them, what's an infection? Well, an infection occurs when germs or bacteria enter our body and multiply, causing illness or disease. And many bacteria that cause infections are actually common normal flora of our bodies. So E. coli is going to be common in our urinary tracts. Staph aureus is going to be common on our skin. Streptococcus pneumoniae is common in our sputum. And so, as I mentioned before, our immune system can typically prevent infections from occurring, but sometimes we may be a little bit immunosuppressed, or we may have a breakdown of barriers that allows these bacteria to cause disease or an infection. Some signs and symptoms of infection that you're probably familiar with. Some universal signs may be a fever. That's our body's way of increasing its internal temperature to make the bacteria uncomfortable and try to eradicate that infection. We can become fatigued because our body's trying to fight off that infection. And we can have an increase in our white blood cell count. Our white blood cells are our body's immune system that helps us fight infections. And so if we have an infection, our body's going to want to make more white blood cells so that we can fight off that infection. Some more specific signs that are, I guess, more specific to certain types of infection would maybe be with the pneumonia, maybe cough and shortness of breath. Burning or pain with urination may be indicative of a urinary tract infection. Redness or swelling of the skin could be a skin infection or a cellulitis. Diarrhea and vomiting may be some sort of sign of an intra-abdominal infection in our GI tracts. And any new onset pain at any area could potentially be indicative of an infection. So we talked a little bit about bacteria and infections. So now we're going to start talking about the antibiotics that we can use to treat these different types of infections. So what are antibiotics? I'm sure we've all dispensed many antibiotics from throughout our time. They're medications that help treat infections caused by bacteria. And these use a variety of mechanisms that we're going to talk about. There's so many different antibiotics: amoxicillin, augmentin, cefuroxime, Keflex, all the different antibiotics, Bactrim, clindamycin, so many different antibiotics. And one of the key things that differentiates them is they have different mechanisms that they use to kill bacteria. And we'll talk about these mechanisms. So what's interesting about antibiotics is that to treat most diseases, we take a medication that causes a change to our body. So if we have high blood pressure, we take a medication that will decrease our blood pressure. If we have diabetes, we'll take a medication that will help decrease our blood sugar. But what's interesting about antibiotics is they're not causing a change directly to our body, or at least that's not the intended outcome. The intention of the antibiotic is to eradicate the bacteria that's causing the infection. So it's a little bit different compared to other medications we may use. And antibiotics are going to have many different mechanisms of action. So bacteria have many different components, and so we can take advantage of that by using different mechanisms to target those different components. So we can use antibiotics that will target the cell wall of the bacteria, that peptidoglycan cell wall we talked about. So beta-lactams include penicillins, cephalosporins like our Keflex and ceftriaxone can target the cell wall of the bacteria. We have antibiotics that can target the plasma membrane, so that helps hold our organelles of the bacteria together. We can target DNA synthesis. So fluoroquinolones such as ciprofloxacin, levofloxacin, these are going to keep our bacteria from being able to effectively replicate. And if they can't replicate, they can't keep growing and causing infections. Ribosomes are important for protein synthesis in our bacteria, so we can use some antibiotics like our macrolides, like azithromycin. We've probably dispensed many Z-Paks before, and then also tetracyclines like doxycycline. Those can target those ribosomes and prevent bacteria from being able to make proteins. And then we can also target the metabolic pathways of the bacteria. So Bactrim or Septra, that'll target one of the metabolic pathways that bacteria use. So if we can stop some of these pathways or attack some of these different systems that the bacteria use, we can eradicate the different types of bacteria. And different types of bacteria, maybe a gram-positive bacteria that has that thick cell wall, maybe we would want to use an antibiotic that would target that cell wall. Whereas if a bacteria doesn't have a cell wall, then we can't really use something that targets a cell wall to kill the bacteria. So some of these things we'll think about as we're talking about pneumonia specifically. Antibiotics have different spectrum of activity or coverage. So some antibiotics are only going to cover gram-positive bacteria. Some are going to cover only gram-negative bacteria. And then most are going to have a little bit of coverage of each. So most of our antibiotics, like our penicillins, amoxicillin, our cephalosporins, like Keflex, our fluoroquinolones, like Cipro and levofloxacin, azithromycin, Bactrim, clindamycin, tetracyclines, these are going to have a little bit of gram-positive coverage and a little bit of gram-negative coverage. So these are typically going to be helpful for a lot of different types of infections, because most types of infections we're concerned about there might be a gram-positive causing it or there might be a gram-negative causing it. So most of our antibiotics are going to have a little bit of coverage of everything. But we have some that are more specialized antibiotics that are only going to target gram-positive organisms, such as our vancomycin. So if you work in a hospital, you've probably seen a lot of vancomycin batched and dispensed on a day-to-day basis. So if you're tubing up that bag of vancomycin, you may be thinking to yourself, the clinician may be thinking that this patient may have an infection caused by a gram-positive bacteria. Daptomycin is an alternative to vancomycin for when we can't use vancomycin, another common gram-positive only antibiotic. And then gram-negative antibiotics, such as our aminoglycosides, our gentamicin, our tobramycin, aztreonam's a unique one. Those are only going to target gram-negative bacteria. And usually we're going to use our gram-positive only or our gram-negative only antibiotics when we're concerned about a more resistant bacteria. Like MRSA is a common gram-positive bacteria, or Pseudomonas aeruginosa is a common resistant gram-negative bacteria. But usually for most infections, we can use something that targets a little bit of both. So what are some different goals we can have when using antibiotics? There can be some different situations we may want to use antibiotics. So maybe we're using it for prophylaxis or prevention of an infection. So a very common time that I see this used in the hospital is before surgeries. So if you've ever had a surgery, your doctor probably told you to take a couple doses of antibiotics before the surgery. Or if you went to the hospital, they may have given you a dose of cefazolin or vancomycin just once before the surgery. And this is because bacteria love it, the breakdown of tissues. And during surgeries, we're cutting into the skin, and that allows bacteria the opportunity to potentially go where it isn't usually and cause an infection. So we can use a single 1 or 2 or 3 doses of antibiotics to help prevent that from happening. So that's going to be prophylaxis. Empiric antibiotics are going to be used when we know or suspect that someone has an infection and we're not exactly sure what it is yet. But we want to use something that is going to cover all of our bases and cover all of the most likely bacteria that it might be. And then definitive therapy is when we've identified what the causative bacteria is, and we can go ahead and use something more narrow and less broad and target just that specific bacteria, because we know what it is, so we don't have to cover everything. We can just cover what we know that it is. So sort of a way to visualize that, imagine the way that we transition from empiric or broad coverage to definitive antibiotics. If someone comes with an infection and we're not really sure what it could be, we may have to cover all of these things that are listed on the slide, all the gram-negatives and all the gram-positives, so we need to use something that's going to cover all of that. But imagine we identify that it's Staphylococcus. We found that Staphylococcus aureus is the cause of the infection. Well, now we can transition to an antibiotic that is just going to target that one bacteria and not give us such broad coverage of everything. We don't do this with every type of infection. Sometimes you'll just start on one antibiotic and complete the course. Patients that come into the hospital, a lot of times they'll start on an IV antibiotic that's pretty broad, and then they may narrow once we get a little more information. But once we do identify what the source is, often we can tailor therapy. So here's a way to visualize the thought process we may go through when deciding what antibiotic we may want to use. So first we need to think about, okay, this patient has an infection. What's the source of the infection? And then we're going to determine, based on that source, what are the most likely bacteria that would be causing that infection. So the types of bacteria we would think would be common for a urinary tract infection or a UTI maybe are different than what would cause a pneumonia most commonly or a skin infection most commonly. So we're going to start with different antibiotics based on the source of infection. We're going to initiate empiric antibiotics based on what we think is most likely to cause that infection. And then we can, once we isolate the causative pathogen, if we're able to do that, we can tailor our antibiotics to target that specific pathogen. Antibiotic side effects. So we've probably all heard patients complain about, that antibiotic made me have diarrhea, or I had a lot of GI upset with that, or I broke out in a rash. But with a few exceptions, most of the direct antibiotics effects that antibiotics are going to have on patients are not desired effects, but more adverse effects caused by maybe allergic reactions that are very common with antibiotics. Antibiotics are some of the most common medications that can cause allergic reactions. I think penicillin allergy is probably the most common allergy in the world. Direct negative effects of antibiotics can be caused, so there are certain side effects associated with certain antibiotics that we need to be aware of, and we'll talk about those later. And then antibiotics, unfortunately, can also alter our normal bacterial flora. So antibiotics are not only going to have an effect on the bacteria we're trying to target that's causing the infection, they can unfortunately have an effect on some of our normal bacteria, like those bacteria that are in our gut that are helping us with digestion. Well, if we upset those bacteria in our gut, that can lead to diarrhea and upset stomach. So just things to think about with antibiotics. So antibiotic allergies we mentioned a little bit, but these are caused when antibiotics and human proteins form complexes, and then our immune system attacks those complexes. So some common side effects or forms of allergies may be hives, rashes, itching. Those are pretty common, and then more severe types of allergic reactions can occur, such as shortness of breath, or anaphylaxis. And so those are more life-threatening allergies that we would want to avoid antibiotics in. The most common antibiotics that cause allergies are going to be penicillin, penicillin, amoxicillin, augmentin, nafcillin, etc. And then sulfa antibiotics as well, our Septra and our Bactrim, very common antibiotics that cause allergic reactions. But we can also have some nausea, diarrhea, headache, other side effects that are different than allergies. They're not true allergies. They're more intolerances to antibiotics or undesired consequences of antibiotics. All right, and then finishing up our antibiotic section, so bacteria can develop resistance to antibiotics, unfortunately. This has been a big topic over the past couple of decades. You may have heard on the news concerns about bacteria becoming resistant to the antibiotics that we use, which is a negative thing, because if we can't use the antibiotics that we like to use because of the bacteria developing resistance to them, then we may have to use alternative antibiotics that may potentially have more side effects than we desire, and then causing even more downstream resistance as well. But bacteria can be smart. They can develop resistance to antibiotics, which is why we want to use antibiotics appropriately to help avoid resistance from developing. So antibiotics can develop a lot of different mechanisms. At the top, you can see they can develop efflux pumps, which will pump our antibiotics out of the bacteria. They can develop ways to decrease the uptake of antibiotics. They can develop inactivating enzymes that are going to inactivate the antibiotic that we're using. And they can also, bacteria are so smart that they can alter the target that our bacteria it can alter the target that our antibiotic is trying to target to make it so that our antibiotic doesn't recognize that target anymore. They can sort of use alternative means of accomplishing their goals so that antibiotics don't recognize it. So we need to try to use antibiotics appropriately to help avoid these downstream consequences, such as decreasing unnecessary antibiotic use. If we don't think that a patient has an infection, or if we think that their infection may be viral in nature, then an antibiotic isn't going to help that. And then using the proper dose. We don't want to underdose antibiotics. We want to use the appropriate doses of antibiotics. because if we give just too little of the antibiotic, then that could just expose the bacteria to the antibiotic so that it becomes familiar with it, but it doesn't actually kill the bacteria. So we want to avoid underdosing, always use our appropriate doses, and then for the shortest effective duration, a lot of times we may think, oh, we'll just use 7 days of antibiotics. That seems like it'll be a good number. But sometimes we can use shorter durations like 5 days and 3 days for certain indications. We want to use the narrowest appropriate antibiotic. We talked about transitioning from empiric to definitive earlier. Whenever we identify what the causative bacteria is, we can transition to an antibiotic that just targets that bacteria. So just to summarize all of the stuff we talked about, there are many types of bacteria that are present in and on our bodies and throughout the environment, and sometimes they can cause infections. We can use a wide variety of antibiotics to treat these infections, and they have many different mechanisms by which they act, which is why we have so many different antibiotics, because there's so many different things we can target in bacteria. Antibiotics are going to work in many different ways, and we should use them appropriately so that we can prevent bacterial resistance, so we can keep using our effective antibiotics and avoid any unnecessary adverse effects. So I'm going to start talking about pneumonia specifically, and we're going to apply some of these principles we talked about. Do I have any questions before I do that? Yes? Mm-hmm. Mm-hmm. So that's a great question. So the question is, why is it that some people will say that they were previously had an allergy to penicillin, but then down the road they say they're not, or we find that they're not allergic to penicillin? There's a few potential options there. One is that we can actually outgrow allergies. Just as sometimes we can develop allergies later in life, my mom developed an allergy to shellfish like 30 years into her life. So sometimes we can develop allergies later in life, but we can also outgrow allergies, so to speak. Another reason for that can be that some people may have been told that they were allergic to penicillins as a child because maybe their parents were afraid of penicillin allergies. So they said, we don't want any of that. Just tell the doctor you're allergic to penicillin and we're going to go use something else. That could be the case. Very commonly in the hospital when we're trying to use antibiotics before surgeries is prophylaxis. We may have ask them, we'll always ask the patient, what was your allergy to penicillin? And sometimes they'll say, I don't know, it happened as a child and I was just told that I had the allergy. So that's a potential thing that it could be as well. And another possibility to think about is that penicillins and cephalosporins are structurally related. They're not the same. So our Keflex and our amoxicillin are structurally related, but they're not the same. So sometimes people may have an allergy to penicillin, but they may actually be able to tolerate cephalosporins because they're a little bit different. So those are just a few potential thoughts. Great question. Anything else?
I have a question related to the gram staining.
Mm-hmm.
I've heard that mycobacteria, like tuberculosis, are like neither gram positive or gram negative. Would you still be able to tell that on the gram staining?
Great question. So the question was, we've heard that mycobacterium are not gram positive and not gram negative. Could you tell that on a gram stain? So a mycobacterium they're going to have sort of a waxy outer coating and are not going to be able to be detected on a gram stain. So you'll know there's bacteria there, but they'll appear translucent because the stain is not going to be able to penetrate that waxy outer layer. So you have to use a specialized stain called an acid-fast stain to stain them. Yeah. Thank you. Audience-approved answers to the question. All right. So I'll move into specifically pneumonia pharmacotherapy. So how do we diagnose and treat pneumonia? And let's apply some of the things that we talked about before. So pneumonia is an infection that inflames the air sacs in one or both of the lungs. Many of us probably know a loved one or ourselves have been affected by pneumonia before. Some common symptoms are going to be shortness of breath, cough, phlegm and sputum production, and this can really range in seriousness from mild to life-threatening. Some patients may be able to be treated as an outpatient, some may need to be hospitalized, and some people may need ICU-level care for management of their pneumonia if the damage to their lungs is significant enough. So we sort of talked about antibiotic prescribing principles earlier, so I like to sort of think of the stepwise assessment of how we're going to manage a patient with pneumonia. So we're going to start off by classifying the type of pneumonia that we think the patient likely has. We'll then identify the most likely pathogens that are going to cause this type of infection. Then we're going to move into selecting appropriate antibiotics to target those bacteria. And then maybe if we get some information, not the best disease state example, and we'll talk about why, but if we can figure out what caused that pneumonia, maybe we can de-escalate our antibiotics and target that specific pathogen. So what are the types of pneumonia? We got CAP, HAP, VAP, and aspiration pneumonia. So really the last one rolls off the tongue. CAP is community-acquired pneumonia, and this is pneumonia that's acquired in the community. HAP, or hospital-acquired pneumonia, is going to be a pneumonia that occurs 48 hours or later after hospitalization. So this is a pneumonia that is acquired when hospitalized. And then VAP is ventilator-acquired pneumonia, which is going to occur in a patient who has been on a ventilator or has been intubated on a ventilator respirator for more than 48 hours. And then aspiration pneumonia is a little bit different in that it occurs when you inhale food, drink, vomit, or saliva into your lungs. So if you inhale things down the wrong tube. So if you've ever had surgery and you've been told not to eat at midnight or after midnight, prevention of aspiration pneumonia is one of the big reasons, because we don't want you to aspirate the contents of your stomach into your lungs when the surgery starts. All right, so how do our patients present with pneumonia? We talked about it a little bit, but confusion and fatigue is common, particularly in elderly patients. 1 second. Yes, question? Yes.
So, a term I am now hearing, never heard before, is COVID pneumonia.
Mm-hmm.
What category is that in?
So COVID pneumonia would fall into COVID pneumonia. So great question. It's sort of, I don't think it would, so we have specific guidelines specific to COVID pneumonia because of how unique and prevalent it is. I guess if you wanted to lump it into one of these, then if you obtained it in the community, then I don't think that categorizing COVID pneumonia into CAP, HAP, or VAP would necessarily be appropriate. Actually, I think it's COVID pneumonia a thing? Yes, but I don't think we would call. So if you said the patient came into the hospital with COVID pneumonia, they have CAP, that would not be entirely correct, because CAP implies that it's caused by a bacterial pathogen likely, or potentially viral. COVID is viral, but COVID pneumonia is so specific that you would just diagnose it as a COVID pneumonia and treat it as such, and we wouldn't lump it into one of these categories.
And is there treatment for COVID pneumonia?
There are quite a few treatments to COVID pneumonia, which would probably take up another 1 hour talk, but yes, there are emergency use authorized medications for COVID pneumonia, and there are FDA approved treatments for COVID pneumonia. So.
And were there those treatments approved with, what strand of COVID was it in August of 2021?
Yeah, so what was approved in August of 2021 strain?
Because
Racking my brain. I think at that time remdesivir was approved. The last few years has been kind of a blur. What happened at which time? Remdesivir was approved. There were a few of our other antivirals that I think had emergency use authorization at that time. Dexamethasone, I think at that time, had already had indication for treatment of pneumonia. Not exactly sure. Maybe we can talk about that after this talk, if you want to talk about it afterwards. Great question. All right, so what does a patient with community-acquired pneumonia, HAP, VAP, or aspiration pneumonia look like? They may be confused. They may have a fever. Remember, our body's trying to increase its temperature to help fight this infection. Leukocytosis is another word for increasing our white blood cell count. So we're going to try to increase our white blood cell count so that we can mount, and that's our body's immune system that's trying to fight that infection. We may have a productive cough because we have bacteria in our lungs and airways. Purulent sputum, meaning that there's white blood cells in our sputum. Chest pain is common with pneumonia, and then rales or a crackling noise is common if you listen to a patient's lung sounds with a stethoscope when they have a pneumonia. And then shortness of breath, of course, because you have bacteria filling the sacs in your lungs, so it makes it hard for you to transfer oxygen in and out of those lungs. So how do we diagnose pneumonia? Chest x-ray is going to be the gold standard. So if you take a look, there's a picture of a chest x-ray. So the left lung is a little closer to what you are. Well, technically it's the right lung, but your view, the left lung is a little bit more of what you would expect to see from a normal healthy lung. There's a little bit of opacity in there, but on the right side you can see the haziness at the bottom of the lung. That is bacterial infection and inflammation. So you can see that on chest x-ray, and that'll be a very strong indicator that you have potentially a bacterial pneumonia. A few other potential things to rule out at that time too. You can do blood cultures, though you're not always going to get isolate something in the blood if the infection's in the lung, but sometimes you can get bacteria that'll go from the lung into the blood if it is there long enough and untreated. We can do that fancy gram stain we talked about and culture the bacteria, though sputum cultures are not always very helpful. We sort of talked about that we don't always get a definitive pathogen with pneumonia because there's a lot of normal flora in our sputum. We have a lot of bacteria in our sputum, and so if you culture someone's sputum, you might get the causative pathogen, or you might get what's called, it'll come back as OPF, oropharyngeal flora, which isn't really helpful in identifying what is causing your symptoms and shortness of breath. We can detect urinary antigens for Legionella and pneumococcal pathogens. These are specific tests that we can use to identify the presence of antigens or toxins to the bacteria in the patient's urine. And then we can do a viral respiratory panel. Viruses are a common cause of respiratory pneumonia, and so we can sometimes identify that as a cause. And we can use a PCR, or polymerase chain reaction, to identify the DNA sequences for the specific bacteria. And we may be able to use a procalcitonin, which is something that's been used a little more recently. It's a biomarker that's released in response to bacterial infections. So if you measured someone's procalcitonin and it was elevated, maybe that means they have a bacterial pneumonia. And if it's normal, then maybe it's a viral pneumonia. All right, I'm just trying to make sure I'm cognizant of time. So the CURB-65 score is a risk stratification tool that we can use to determine how severe the patient's pneumonia is and where do we need to treat them based on how severe it is. So the score has 5 criteria listed at the top. So confusion, urea level being elevated, if the patient has an elevated respiratory rate because they're really having to work hard to breathe, if their blood pressure is low because of the bacterial infection, or if they're elderly. You get 1 point for each of those 5 criteria if you have it. A lower score is going to mean that they're at a lower risk of severe negative outcomes of the infection. So you may be able to treat them as an outpatient. If their score is 2, that may mean they have a higher risk of mortality or death from the pneumonia, and so you may want to treat them in the hospital. And then if they have a score of 3 or more, they may warrant ICU level care. So thinking about our pneumonia stepwise assessment, so we've figured out what type of pneumonia the patient has. Now we want to think about what are the common pathogens that we need to target. So the common CAP pathogens, community-acquired pneumonia pathogens, respiratory viruses are a very common cause, and sometimes patients don't need antibiotics to treat a pneumonia. Our most common bacterial pathogen is going to be Streptococcus pneumoniae, which is a gram-positive, which is why it's in purple, and then followed by Haemophilus influenza and Moraxella catarrhalis. These are going to be gram-negative bacteria. And there's also a few atypical bacteria that are listed in red, and these are bacteria that don't have cell walls. So if we want to target these bacteria, we need to use something that doesn't target the cell wall, because if we're using an antibiotic that targets the cell wall, then it's not going to be effective against a bacteria that already lives without a cell wall. And then there's a few drug-resistant pathogens like Staphylococcus aureus, including methicillin-resistant Staph aureus or MRSA. Pseudomonas aeruginosa is a gram-negative bacteria that it's drug-resistant. A few other nosocomial or healthcare-associated bacteria. We'll talk about what may put a patient at risk for some of these drug-resistant pathogens. But the ones on the left are going to be the ones that you're going to be most concerned for in a patient that just presents with CAP, and we're going to make sure we cover those. So then we need to start thinking about what antibiotics do we want to select based on those bacteria that we think are most likely. So if a patient doesn't have any specific comorbidities like heart disease, lung disease, liver disease, kidney disease at baseline, a few other things, then we could use the antibiotics listed on the top. So we could use a macrolide, azithromycin. You've probably dispensed many azithromycin Z-packs. For patients with pneumonia, this is going to be one of our most common antibiotics used for the treatment of pneumonia. And then you could also use amoxicillin or doxycycline. If patients do have the presence of one of those comorbidities I mentioned, such as chronic heart, lung, liver, kidney disease, diabetes, alcoholism, malignancy, or they don't have a spleen, then we would want to use one of the antibiotics listed on the bottom. So Augmentin is a pretty good broad antibiotic. Our cephalosporins, a really common cephalosporin, maybe cefuroxime, ceftonir. Keflex may be a little narrow, but you can use Keflex. And then you need to add a macrolide or doxycycline. And then the reason for that is because Augmentin and cephalosporins, they target cell walls. So if we're concerned that it might be one of those atypical red bacteria that don't have cell walls, we need to use something that doesn't target a cell wall. You could also use a respiratory fluoroquinolone. A respiratory fluoroquinolone excludes ciprofloxacin because ciprofloxacin does not have adequate coverage of Streptococcus pneumoniae, which is our most common pathogen. So we would use levofloxacin or Levaquin or moxifloxacin, brand name Avelox. So this is going to be outpatient therapy. We need to consider if a patient has any risk factors for drug-resistant bacteria, and if so, we may want to tailor our therapy appropriately. But if they've previously you've previously cultured respiratory MRSA, methicillin-resistant Staph aureus, or Pseudomonas aeruginosa, you're going to want to cover those pathogens. Or if your patient's recently been hospitalized within the last 3 months and received antibiotics, then through an IV route, parenteral antibiotics specifically, then you would want to be a little bit concerned for drug-resistant bacteria, such as our Staph aureus and our Pseudomonas aeruginosa. So we can't always use a Z-Pak for our pneumonia, and this is why. This is sort of a picture of what's called an antibiogram, and an antibiogram will tell you in your area, so antibiograms are regional, so the antibiogram for this triangle area may be different than in Durham, where I work, may be different than Nebraska, where a lot of you came from. So an antibiogram is regional, and so it'll tell you how often are certain antibiotics effective against specific bacteria. So remember I said Streptococcus pneumoniae is going to be our most common bacteria that causes bacterial pneumonia. This antibiogram for our region, this is a few years ago, shows that 26% of the time, erythromycin, which is similar to azithromycin or Z-Pak, was resistant to strep pneumoniae. So I don't really want an antibiotic that is not going to be effective not going to be effective a quarter of the time. So in areas where your resistance to azithromycin is higher, you may want to use a different agent instead of a Z-Pak. So then that's not to say that in all areas we shouldn't use Z-Paks as monotherapy, but in certain areas our doctors need to be thinking about that. All right, and then community-acquired pneumonia inpatient therapy. For a non-severe patient, we can use probably our go-to most common is going to be ceftriaxone plus azithromycin, so beta-lactam plus a macrolide. We could use a respiratory fluoroquinolone. Our severe inpatients, we could use a ceftriaxone plus azithromycin still, or we may want to use a beta-lactam plus a fluoroquinolone. And then if they've previously had MRSA isolated, then you would want to add something like maybe a vancomycin that'll cover MRSA. And if they've previously cultured Pseudomonas aeruginosa, our resistant gram-negative bacteria, then we may want to add something that's going to cover that. So if you see a patient that's prescribed Zosyn or cefepime, those are really commonly used in the hospital setting for coverage of Pseudomonas. And then on an outpatient basis, our options are more limited for Pseudomonas coverage, but our fluoroquinolones can cover that, such as our levofloxacin or our ciprofloxacin. All right. When will we consider adding MRSA coverage? We already mentioned if they've previously had MRSA, we would want to consider covering for MRSA. Or if a patient presents with like sepsis, which is essentially meaning that your organ function is dysregulated due to how severe the infection is, then we would want to consider adding coverage for MRSA. If the patient has respiratory failure, we would want to add MRSA as well, or add MRSA coverage. And vancomycin is going to be our most common antibiotic used for MRSA coverage in a hospital setting, linezolid potentially. In a hospital setting, we use daptomycin for MRSA coverage sometimes, but we cannot use that for a pneumonia because it's not going to be effective for infections in the lungs. The surfactant that coats our lungs inactivates daptomycin, so we can't use it for respiratory infections. And then here are our options for, and I guess just to say, on an outpatient basis, sometimes we'll use Bactrim, clindamycin, or doxycycline for coverage of MRSA. Sometimes you can use linezolid as well in an outpatient setting. It's a little more expensive and usually reserved for later lines of therapy. And then our antibiotics that cover Pseudomonas are going to be our aminoglycosides, so our gentamicin, our tobramycin, our fluoroquinolones, that ciprofloxacin, levofloxacin, they will cover Pseudomonas. Moxifloxacin does not. And then we could use an anti-pseudomonal beta-lactam. And those are probably going to be what's most commonly used in an inpatient basis for Pseudomonas coverage, and that's going to be your cefepime, your Zosyn, or also known as piperacillin tazobactam, and then our meropenem. Those are probably going to be your go-tos typically for pseudomonal coverage, or you could use one of those fluoroquinolones as well. Aminoglycosides usually aren't used first line because they're a little more difficult to dose and have a risk of kidney harm to our kidneys. And a few additional considerations wrapping up. So again, for a hospital-acquired or a ventilator-associated pneumonia, so if you get a pneumonia after 48 hours that you've been in the hospital, then we would want to be concerned for covering MRSA and Pseudomonas, and we would want to add something to cover those. And then aspiration pneumonia, previously guidelines recommended covering anaerobes, which are bacteria that don't need oxygen to grow and develop, but current guidelines no longer routinely recommend using anaerobic coverage unless there's specific circumstances. So we talked earlier about all the different side effects that antibiotics can have. Here are a few of them to note, the ones that our pharmacists are going to be looking at and thinking about whenever we see a prescription for these antibiotics. Our beta-lactams, like our penicillins and our cephalosporins, we want to make sure that we're adjusting the dose for their kidney function. We have a few antibiotics, such as azithromycin and our fluoroquinolones, which are going to potentially be proarrhythmic if not monitored appropriately. We have renal adjustments for quite a few of these antibiotics. There are several we want to avoid in pregnancy, such as our fluoroquinolones and our doxycycline. And then there are a few that we want to avoid giving with calcium products or iron products because they will bind to those products and inactivate it. So if you take your doxycycline or your Cipro with iron or with calcium, it can bind to it and inactivate it, and that's not going to be a very effective antibiotic. So we counsel our patients to separate those antibiotics from any of our morning medications, including calcium or iron. Okay. And then finally, we want to de-escalate our antibiotics. So we've identified what the potential causative pathogens are. We started some antibiotics, and now potentially we want to de-escalate those antibiotics if we can. This is going to be difficult in pneumonia, as I mentioned. We can't always culture the causative pathogen in pneumonia, but sometimes we can. Transition from intravenous to oral antibiotics, if the patient is in a hospital, typically they're going to start with IV antibiotics. You might start on ceftriaxone or potentially a Zosyn or vancomycin, and then once the patient is feeling better, we need to think about what oral antibiotics can we transition to. So if they're on ceftriaxone, maybe we'll go to a cefuroxime, maybe a Keflex, maybe a Ceftonir, or one of the many, many different cephalosporins. Maybe we'll go to Augmentin. So thinking about what do we want to use instead. And then we're typically going to treat for a total of 5 to 7 days. And we want to counsel our patients as appropriate. So there's so many different antibiotics that I could do a full talk on what to counsel patients on for each antibiotic. But we want to counsel them for all antibiotics to complete the full course of therapy and not just stop taking them when they start feeling better, because that would increase the risk of resistance down the road. And then for our patients that it is appropriate for, we want to recommend pneumococcal vaccines. They're recommended for all infants, children who have not been previously vaccinated, or with certain medical conditions. There are specific schedules. Adults with specific conditions, it's recommended to get vaccination before age 65. And then for all adults age 65 and older, it's recommended to receive the pneumococcal vaccinations as well. And schedules vary, and it's becoming more and more complicated as they develop more and more vaccines, but they're all very effective. I've listed the ones that are now commercially available. Previously, the ones that were available were the PCV13 and the PPSV23. More recently, the PCV15 and the PCV20 have been approved. But there are many different vaccination schedules. You can consult the CDC website for all of the different vaccination schedules. Here are my references, and I'm happy to take any questions. Okay, burgundy mask? So the question is, if antibiotic can kill our normal gut flora and then cause adverse effects like C. diff, how do we treat with another antibiotic? So we can try to use antibiotics that don't cause C. diff as frequently. So there's been a lot of studies showing that fluoroquinolones, our 3rd and 4th generation cephalosporins like ceftriaxone, unfortunately, cefepime, clindamycin, those put people at a higher risk of C. diff. And so sometimes we can try to avoid those antibiotics if we can to avoid causing C. diff. If a patient has previously had C. diff, there's some literature to support using oral vancomycin as prophylaxis. So if you work in a community setting, if you ever dispense oral vancomycin, that's what you're dispensing it for, is either the treatment or prevention of C. diff. So there's some evidence that if someone has a lot of recurrent C. diff episodes, you could use oral vancomycin as prophylaxis while you're using the antibiotics that you need to target the other infection. But unfortunately, that is a negative consequence of antibiotics. And also, we can try to avoid antibiotics that are as broad spectrum or more broad spectrum antibiotics that target a lot of bacteria are more likely to upset that normal bacterial flora, whereas the narrower you get, the less likely it is that that antibiotic is going to cause C. diff or impair the normal flora. And usually it's going to be gram-negative antibiotics that are going to harm our normal flora more so than our gram-positive ones. But does that answer the question? Great. There was another question. Yes?
You mentioned that certain antibiotics are either more effective or less effective depending on the region. Why is that? Is it environmental or?
Yeah, great question. So the question is, antibiotics can be more or less effective based on the region. And that is because probably the most direct, there's a lot of different things that lead to that, but it can be based on prescribing practices in the region. So say in one township, all of the providers prescribe fluoroquinolones, like that's their first antibiotic that they prescribe for everything. Over time, if that township has been exposed to, almost everyone in that township has been exposed to fluoroquinolones, then you have a higher risk of the bacteria in that region being resistant to fluoroquinolones. And then bacteria can translocate their resistance to other bacteria. So it's the biggest thing is what has been the antibiotic use in that area over what period, and then how does that downstream affect antibiotic resistance. But there's a lot of different factors. Yes.
It could also be a possibility that they grow according to what temperature they're at, and the gram-positives will grow more in the body at 37 degrees Celsius, and the gram-negatives when it's lower temperature.
So the question is, are there certain bacteria that may thrive at higher temperatures, whereas certain bacteria may thrive at lower temperatures? Yes, there's certain areas in the world where you're going to have certain types of bacteria thrive more so because it is because of just how the environment is there, whether that's really hot, where it's really damp and moist. There's a lot of salt water, a lot of brackish water. Some environmental factors are going to. Hmm?
Like the gram-positive at 37 degrees, like that's what caused the disease in the body. They grow at that temperature. The gram-negative is that's why you have like most urinary tract infection is gram-negative as opposed to upper body bacteria will be like grow at 36 degrees. That's what I meant to say.
Okay.
So that question.
Oh, okay. Well, thank you very much. Yeah, and many areas of the body, like our body tries to maintain a similar temperature throughout the 98.6. But yeah, there are certain areas of our body that do have different temperatures, so that can impact bacterial growth. Yes.
Why are two antibiotics prescribed for diverticulitis? And in my case, my second attack, I was sent to a specialist, infection specialist, and she had to switch my second one. It was like Cipro and something. And it was 3 months before they could clear my gut.
Mm-hmm. So the reason for using multiple antibiotics would typically be because the first antibiotic doesn't cover everything, so we have to add the second antibiotic. So when targeting something in the gut, we're worried about a few gram negatives and a couple gram positives, but we're also worried about anaerobes as well. And so it might have been Cipro and Flagyl, metronidazole. So the metronidazole is going to cover anaerobes, those bacteria that thrive without oxygen.
The Flagyl made me so sick
Mm.
that I had to stop taking that, and they sent me to a different doctor, and they switched, I think it was clindamycin or something.
Mm-hmm. Yeah, and so that's another one that covers anaerobes. There's not that many antibiotics that cover anaerobes, but so if we're using multiple antibiotics, it's because the one wouldn't cover everything, so we had to cover the next one. So a very common regimen in the hospital setting is going to be vancomycin plus Zosyn or vancomycin plus cefepime, because the vancomycin is going to cover that MRSA that we're concerned about, some of our resistant gram-positives, and then the Zosyn is going to cover most everything else.
I just want to thank you for an excellent and thorough presentation.
Thank you very much. I appreciate it. That means a lot. It's an honor to be here. Thank you so much for being such a great audience. It's been my pleasure.